There are other times where chart audits are required as part of this program or that program or, whatever. Let's say you get some deficiencies, now you have a plan of corrections, you have to chart audit around that. So there will be times that you will have a number that you need to hit. And certain states have certain requirements as well. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we're going to be talking about chart audits. But first, if you like our content, please like, share, and subscribe. So, what are chart audits? Well, if you've been in the industry for more than 10 seconds, you are very, very familiar with audits and specifically chart audits. These can also be called clinical record reviews or just record reviews, but really what we're talking about are people checking charts for compliance. Like, long story short, that's what we're doing. You can check charts at 2 time points: during service and after service. So it could be while somebody is on service and receiving the care, or it could be once they're discharged and you're looking back at the entire picture of the chart. And there are benefits to both. That is why typically a good chart audit program is going to include some number of active charts and some number of discharge charts. So what are the benefits to active chart audits versus discharge chart audits? With active chart audits, the benefits are that if you find problems, you can correct them in real time. Of course, if those problems were like before and they're not like correctable backwards, that's fine. But you do get a chance to resolve, let's say, a question or a process that was undone, or a question that was, or like, let's say you didn't address something that you found on an OASIS in a care plan. You have the time to create an addendum and to address the problem ultimately. When a surveyor is in your office, they are essentially also doing a clinical record review. This is how they can figure out if you've been compliant or not. That's why, similarly, you should do clinical record reviews to figure out if you were compliant or not. In the moment of patient care, sometimes life just gets in the way and people have a hard time doing things on time, submitting things on time, or checking every important box, following every important process step. The audit process gives you a look into what's going on in your agency in terms of the clinical kind of service and records and documentation, so that you can both correct in the moment and for future. The biggest benefit of doing active chart audits is just the ability to catch problems as they're happening. But the con to doing active chart audits, and why you should also incorporate discharge chart audits, is while a patient is active, you don't see the full picture. Since we have possibly a variety of clinicians on the case performing their visits at different time points, they are also probably submitting their documentation in different time points. Of course, the requirement is that the documentation is in the office within 7 days of the visit. But in real life, unfortunately, that's not always the case. And so in a best case scenario, you are always in an active chart audit, still not getting today's snapshot. You are still getting a snapshot from 7 days ago. It's kind of like when you're looking at the stars. When you look up at the stars of the night sky, it's not today's night sky that you see. You see the night sky that took light years to travel to your eyes. That is what an active chart audit is. We're looking at a snapshot of what it looked like a little bit before. Well, I guess that's the discharge chart too. With actives though, we don't know, is it the complete picture or not? Would we like to have it be that today reflects exactly 7 days ago? Yes, we would. But in real life, sometimes that's just not the case. And the truth is, one of the hardest parts of running an agency is just getting documentation back on time, whether it's signed from the doctor or, the notes from this RN or this ST or this clinician or that. That is, in my experience, the most difficult part of running an agency is just getting your notes back on time. If you have your notes back on time, from there, QAing, the office stuff, that stuff's a lot easier. It's just getting it. That's the hardest part. That's where the discharge chart audit plays a really big role. Because when you're doing a discharge chart audit, you see the full picture, whether it's complete in terms of like, did they fill this note out properly? Did they miss something? Things like that. We don't know. But what we do know is that more or less every piece of paper that should be in the chart is in the chart, or that will be in the chart. There is a lot of value to reviewing a discharge chart that's missing stuff, because then you can identify the people that are bringing things late or not submitting at all, or, I don't know, whatever the problem may be. And you could see how the care kind of like moves and evolves over time. And you could also see how and if the various disciplines are interacting with each other. In hospice, it's a lot easier to get the disciplines to interact with each other because you have the IDG meetings required by law every 15 days or 14 days. But in home health, there is a required case conference at the beginning of the episode when you have multidiscipline, but throughout the episode, there's really not much communication between the disciplines unless something happens or, but from a regulatory standpoint, you're not mandatorily meeting every 2 weeks, all of you, and talking about the case. So chart audits give you an insight into your clinical processes. This is the same insight that a surveyor is going to get. And so it's highly valuable because you might go with a clinician to the field and they might be a perfect clinician. But if they're not documenting according to rules, regulations, standards of care, and just basically are let's say not good with paperwork, your chart is going to paint a very different picture than the actual care that's happening. So we need to chart audit to find holes in our processes so that we can fix them, with the goal of improving patient care, making stronger documentation that ultimately, if it gets ADR'd, you're going to pass the ADR, and identifying problems in a time frame that is fixable for the chart. When I say fixable, little asterisks, I don't know, how do you make that little asterisk? Little asterisk, when I say fixable, you cannot fix a note from before. That's not a thing. But you can have addendums, clarifications, and things like that. We will have a whole separate video on how to update charts and things like that. How to fix charts essentially. If you find a problem, but it's been a while, what you can and cannot do. We'll go over all of that in a separate topic. But long story short, you need to be chart auditing. Both home health and hospice are required to chart audit by CMS. However, CMS doesn't specify the number of charts or the time frame within which this number of charts needs to be reviewed. They do, however, specify the clinical record reviews need to be done as part of the general annual agency evaluation. Need to be done more or less periodically, quarterly, whatever, things like that. And as part of your QAPI program. There is no way to run an effective QAPI program without incorporating chart audits into it. So outside of it being a legal requirement and a conditional requirement to pass survey, it is also a very critical piece that it's going to inform your QAPI. Because the standardized sources that you can get, for example, IKEYs or, OBQI, whatever, things like that, or HIS reports and stuff like that, they're going to give you some critical pieces of information. But they're not going to give you the in-depth kind of knowledge that you could see for your process and your clinical care that a chart audit can give you. So what are the rules around chart audits? Essentially, you got to do them. You got to do them periodically. I would suggest monthly or quarterly. You got to do some on active. You got to do some on discharge. Long story short, there are other times where chart audits are required as part of this program or that program or, whatever. Let's say you get some deficiencies, now you have a plan of corrections, you have to chart audit around that. So there will be times that you will have a number that you need to hit. And certain states have certain requirements as well. For example, in California, you have to chart audit at least 5% of your total patient census with a minimum of 20 records and a maximum of 100 records. This is the California law. But state to state laws may differ. There are some states that don't have any licensure requirements at all for home health or hospice. And that's cool, if you're in a state like that, good for you. But with our administrative compliance program, we like to match the highest regulatory requirements in the country. And so we match California's rules because California and New York are essentially like the most regulated states in terms of like home health and hospice. And so if you match California rules, then you're probably fine everywhere else. But please look into the rules of your state to see if there's some minimum, maximum percentage or whatever requirement so that you are compliant. With chart audits, here are some other kind of pertinent rules and regulations around them that are in the text of both, actually, honestly, both California and CMS, but we're really just going to focus on CMS. I'm not going to break down like the California rules and stuff like that because not all of you are in California. So whatever, it's not applicable. With CMS, they want you to audit a representative sample of your charts. So what that means is if your patient cases generally have a good amount of every available discipline, whether it's home health or hospice, and with home health, you'll see this a lot more in terms of like single discipline cases, things like that. With hospice, typically you are going to have multiple disciplines on the chart every single time. But let's say you have in your patient population, just every discipline is involved one way or another. Not with every patient necessarily, but throughout the whole case of patients, you're using every discipline. Well, then your chart audits, your sample, your random sample, or however it is you choose your chart audits, need to include at least one of every discipline. You can't just audit only the SN only charts or like only charts with this and not this. Or for example, if you have a good chunk of like wound cases, right? A wound case needs to be part of the sample that you're chart auditing so that you get a good idea of like every kind of service you provide or every discipline and how they interact. People typically will have a couple of methods of selecting charts for chart audits. It's either a random selection, like literally like, I don't know, pick numbers out of a hat for medical record numbers, I don't know, some random selection, or they're selecting charts on purpose. If you're going to select charts specific, like I know this specific chart now, we need to chart audit it, please select charts that are the hardest cases, the cases with the most disciplines, the cases with home health aides specifically, and any cases with difficult patients. The differentiation of hard cases and hard patients are you might have like a patient clinical care moment with wound IV, all these like kind of like hands-on, a lot of direct services, or like a wound that just doesn't heal, or I don't know, like this is a difficult case. And then you have difficult patients, maybe they complain a lot, they demand a lot, highly litigious, lots of family involvement and everyone has a say, and sometimes there's conflict between the family or whatever. You want both. There is nothing wrong with either one. I'm not trying to like color, like, say anything bad about like demanding patients, let's say. My point is you want to audit those charts specifically, because in those charts with a difficult patient, you're going to have a lot of opportunity to see if complaints are being logged properly, being reacted to in a timely fashion. Is your staff reactive? Are they late? The more difficult patients are going to tell you every time anyone messes up. They're also generally going to read your consents more and understand what's expected of the service more, and then let you know when that doesn't happen, things like that. So you really want to audit those cases, A, just to make sure that you're like doing it right. B, it'll be if you audit those cases while they're active, specifically, you will have opportunities to pick up things that you may have dropped off. And I say this with the most compassion possible, because when you have a case that you are a patient that you're treating, and that patient is seeing like a PT, an OT, a home health aide, like let's say like in home health, right? Like a nurse, there's a social worker, I don't know what. And they're like complaining about it and this and that. It's already hard from the office perspective to keep all of that together. And then on top of that, if they're like highly demanding, sticklers for time, like, oh, my nurse is 5 minutes late, what's going on, things like that. It's really hard to keep those cases together. So please, for your act, if you're just selecting, like not at random, but just like actually selecting charts, please select those specific cases, especially the cases with difficult patients. Another big requirement is that you want to chart audit on standardized audit tools. What that means is that, like, I can't audit this chart with this philosophy and these ideas and that chart with this other philosophy. You are auditing against the standard set. That's not to say that your chart audit can't evolve over time, or like, let's say, okay, I have wound, so I'm going to have specific to wound things here, versus this one doesn't have wound, so I'm not going to have those. I'm not going to audit for that stuff. That's understandable. But the point is you have some kind of standardized base that you go off of, versus just a person looking at something and like making notes without any kind of standardized form that they're working off. Surveyors want to see a standardized form. If you want to go like hardcore pro tip, when you have QAPI and these other things, I mean, for our compliance program, we do this for people. You add to your chart audit based on whatever it is. I mean, this is like what's expected, but like no one does it. But like we try to incorporate this in our compliance program to the best of our ability, that like if we're doing a QAPI of this, of that, then now we're giving you additional materials to chart audit off of. So the point of all of this is to capture your process and improve it. And so chart audits are a base for your QAPI program. Please make sure you incorporate them in there. And lastly, when surveyors are at your office, they are also essentially auditing your charts. They will ask you to see your chart audits. So you need to have these standardized forms completed, let's say monthly or quarterly. Your policy needs to reflect the scope and frequency of your chart audit. So please don't just like randomly chart audit. Go and see what your policy says and do it according to policy, or change your policy so that the policy is done according to your real life. When a surveyor is on site, they are looking at your chart audits to see a couple of things. First of all, they're looking for patterns of problems, and if you've caught those patterns of problems. Secondly, They are looking to see how you address patterned, both individual and patterned issues that you've come up with, and if those issues resolve over time based on this process. They are also going to ask you and review, how are you selecting charts? Most people just say random, but you could say, we take our hardest cases in chart audit on it. Like, it's up to you. Policies will typically have more of a random selection. So whatever it is you say needs to match what's written. Going back to our continuity video and article, all of this stuff needs to talk to each other and speak the same language. And they are looking to make sure that your review process captures the complexity of the chart. So just like I said earlier, if you have two charts, right, and one is just like basic nursing teachings, whatever, and then the other one is like an unhealable wound for like 8 months, right? Yes, there's a standardized base that you're auditing on, but you can't like not look at the elements of wound care as part of your chart audit when you're auditing the wound. So they're trying to understand if you are, when you are chart auditing, if you are auditing to the scope of the patient care problems. Next, when they're chart auditing your clinical records, they are looking to see if you are following your policies and processes. And so when you are chart auditing, you should also look to make sure that the policy is followed, not just the rule. Because a lot of times the policies, especially if you like buy it from some random place, they're going to go above and beyond from the rules. I don't like that. I don't like any going above and beyond from the rules. In our program, to the best of our ability, the rule, we hit the rule and we stay there. We don't go above and beyond from the rule. Instead, we try to perfect our processes within the rule. And they're looking to see if the care you are providing is in line with a patient's highest potential outcome, whatever that means. In hospice care, it's comfort. In home health, it's rehabilitation. But they want to see that you're setting goals appropriately and that you are doing the things to actually reach those goals. That's what surveyors are going to look for in your charts. And that is how they're looking at your chart audits. They want to see that you are also looking for that stuff as part of your chart audit. So when you are kind of thinking about how to audit a chart, of course you can like buy this tool or that tool, and that's great. Good for you, and as you should. And I don't think that people need to like make every material from scratch, like why reinvent the wheel? A lot of things are already out there. But some important things. You want to make sure, especially in hospice, but like in home health, this is relevant too, that patients' rights are addressed and provided in whatever format is important to your specific industry. That absolutely needs to be part of a chart audit because it is part of the surveyor's thing that they're looking at, and it is a big, big, big place for conditions. 2, timeframes. 3, that every piece is in there. No one forgot to submit this COM note, this MD order, this whatever. Every piece is in there. 4, the things identified in your eval carry into your care plan, carry into your documentation. 5, how do medications interact with all of this? Did you run interactions checks? How are you teaching on meds, and so on? Anyways, that's its own whole separate video. We can talk about elements of care and how to audit for them and stuff like that all day long. The point is that when you are chart auditing, please either audit your hardest cases or random samples that are representative of your total patient care, like kind of census and community. please, please, please make sure that you are checking timeframes and patient rights stuff, big problems. And when you're auditing, audit from the perspective of, are we following our policies, not just the rules? Because that is how surveyors are going to look at it. And in an active chart, the big goal of the active chart is to like find issues that we can still address during the patient care episode or subsequent episode, whatever, at some time. Because if you have a surveyor on site and they see that, oh, you missed something, but then at some point you caught it and you fixed it, like you not fixed it, but addressed it, that, you know, different case by case, but like that could be like not a deficiency anymore or less of a deficiency. If it's a big thing, it can go down from condition to standard and things like that. So definitely active charts, try to go on your hardest cases and pay extra attention to home health aid charts. Surveyors specifically look at those, call those out, and like really scrutinize those on time frames that you're doing supervision properly and like on time and things like that. So that is chart auditing. My name is Mariam Treystman from the Home Health Consultant. I hope you found this helpful. And if you like our content, please like, share, and subscribe. Thank you.